Thank you, Dr. Padma, for this opportunity. Good morning, everybody. It's so cold outside, still you are all here. I can understand that you are interested in fixing the double trouble. Okay, all of us are trying to see what could be the causes for this. Now, when the problem is not with the commando, or with the nerve, or with the neuromuscular junction, who else can be the offender here? We have to think about the extraocular muscles and the periorbital. Now, usually as neuro-ophthalmologists, we are very well versed with the evaluation of the neurogenic causes. Now, at what point do we think about myogenic causes? What are the pop-up signals which will make us think about these things? One is proptosis. You can see the proptosis here with lid retraction and the enophthalmos, or the periorbital fullness with ptosis, congestion over the extraocular muscles, and arterialization of the conjunctival vessels. These are some clues that we have to think otherwise for this condition of double vision. Now, before we go ahead with evaluation of any condition, before we ask history, we should know what are the common causes and the probable causes. Only then we can ask proper questions and we can use our eyes and brain to see and hear what we need to see. So the commonest causes for the myogenic problems would be a thyroid-related orbitopathy and orbital trauma with muscle entrapment. Next comes the orbital inflammatory disease. What we usually see is a non-specific orbital inflammation. But we also have to keep in mind about the specific conditions like sarcoidosis, vaginous granulomatosis, connective tissue disorders like SLE and GCA. The other probable causes are, one is tumors which would affect the extraocular muscles, lymphoma, metastasis and rhabdomyosarcoma. We also have to keep in mind infections, cellulitis, cysticercosis and trichinosis. Venous congestion of the extraocular muscles can cause double vision in CCF and cavernous sinus thrombosis. Or infiltration can occur due to amyloid. We also should keep in mind acquired Brown syndrome and post-cataract surgery muscle injuries. And the first step would be a proper history. Our professors always say, allow the patient to talk and the patient will give you the diagnosis. As my friend said, we have to first understand whether it is a horizontal double vision or a vertical one and which gazes it is worse. This gives us a clue as to what are the extraocular muscles we are looking at and whether it is variable. If it is worse in the morning, it is thyroid-related orbitopathy. If it is worse in the evening, it's myasthenia. And in history, we have to ask these things about onset and duration. It's very important for our DD. Because if the onset is acute, we are going to think about inflammatory disorders. And if it is chronic, usually we will first think about thyroid-related orbitopathy and then benign tumors. And the duration also. And progression and whether it's painful or painless. The details regarding this, we will come to it when we see the cases. And whether there is associated redness, protrusion of eyeball, any fever to rule out infections, any history of trauma to think about entrapments, and any ocular surgery, because even post-cataract surgery following an infiltration of the local anesthetic, we can have double vision due to the myotoxic effect or hematoma itself. And any history suggesting altered thyroid status, respiratory system, renal system, skin and joint lesions. We have to ask because we deal with multi-system disorders. This gives us a clue as to whether we could be dealing with a specific condition here and any other swelling in the body. Before we go ahead with the evaluation part, we should understand something basic about a neurogenic problem and a myogenic problem. As we see here, this is a right lateral rectus palsy. So the right lateral rectus is paretic and the eye has turned to the opposite side because the medial rectus is overacting. And we have a ET here. And when we check secondary deviation and primary deviation, the secondary deviation is going to be much more overaction than the primary deviation. because of the Herring's law. But when we come to a myogenic cause, the muscle which is the offender here is fibrotic or has some deposits inside or fluid because of inflammation. You can see in this picture, you have hypotropia in the right eye. Here the offender is the right inferior rectus, but the eye is deviated towards the muscle itself, the offender muscle itself, and depression and elevation was restricted. Here when the muscle is weak, the eye is turning to the opposite side. Here when the muscle is inflammatory or fibrotic, eye is turning towards the offender muscle itself. So in initial stages, we can have secondary deviation slightly more than the primary deviation, because initially with mild inflammation, the muscle is not able to contract properly. So it can present like a paretic problem itself. But as the inflammation becomes more, or when it becomes fibrotic, what happens? It cannot contract, as well as it cannot release the eye to the opposite side. So we have restriction of movements on both the sides. Think of a blowout fracture. We have depression and elevation restriction. This was a post-cataract surgery eye. And with evaluation, when we look at lids, we have to look for lid retraction, ptosis, and any dilated vessels to think about congestion stasis. And periocular, we have to look for fullness, redness, and ecchymosis to give us a clue about the trauma or inflammations. In conjunctiva, we have to look for arterialization of conjunctival vessels or any congestion over the extraocular muscles, or any localized congestion which could be due to a cyst or a Solomons patch also. And eye position, whether it is in exotropia or hypotropia or exophthalmos or enophthalmos, we have to make a note of it. And then the extraocular movement we have to assess. And fundus, we have to look for disc edema, any venous congestions, any choroidal folds, because any space occupying lesion behind the globe can cause these things. And also look for any vasculitis, which could give us a sign to the specific etiology. And if there is a proptosis, we have to do a detailed evaluation of it. And we have our office test, diplopia charting, Hess charting to help us, and Hettel's exophthalmometry. And if we are in doubt, we can do a forced duction test. For example, if the abduction is restricted, when we try to move the eyeball to the lateral position or the weak area, if it is freely moving, that means it's a paretic muscle. If we feel a tug at that point, that means it's a fibrotic medial rectus which is not leaving the eye into the lateral position. Now, when we have finished this, we should be able to come to a probable diagnosis as to what could be the nature of lesion. Whether it is thyroid related or an inflammatory lesion. Inflammatory could be non-infectious or infectious or traumatic, or be dealing with tumors. Then, to confirm our clinical impression, we have to use the investigations. Lab test would be the basic TCDC ESR, and then additional tests like serum ACE, serum ANA, C-ANCA and P-ANCA, we have to use where we need it according to the cases, the CRP also. And orbital USG would help us to look for the extraocular muscle thickness or retroorbital lesions, and a CT with contrast enhanced and MRI with fat suppression and contrast enhancement would be confirmatory. We will see where we will use the orbital biopsy also. Now this is a 40-year-old gentleman presenting with discomfort in right eye and double vision of 1 month duration. It is gradual in onset, it's associated with redness, and it's worse in the morning. There is no systemic illness, no history of fever or trauma. On evaluation, we can see that vision, fundus and pupils were normal. We can see here the lid retraction and the mild prominence of the eye. We can see the lid lag here on down gaze. This will easily tell us that this is a thyroid related orbitopathy. And here we can see mild adduction restriction and an abduction restriction and elevation restriction here. And Hertel shows a mild proptosis and resistance was positive. And you can see the untraction here for the lateral rectus and the elevation. It hasn't yet still gone into the fibrotic stage. Now, here I am thinking of TRO and pseudotumor as DD. We can think, why are we thinking about pseudotumor here? This patient was referred to us as query pseudotumor, query TRO. Initially I wondered why they thought about pseudotumor in this case, where we have a lid retraction and a lid lag. It is pretty obvious that it is thyroid. But later I understood that their thought process was very good. When I saw the investigations, he had imaging, blood investigations, everything, and he was started on steroids. You can see the blood investigations were normal completely. ESR was also normal. They have done the thyroid profile, it was normal. And they have done TSH receptor antibodies, and that turned out to be negative. And you can see in imaging here, the superior rectus muscle is enlarged here, and the lateral rectus is enlarged, and a mild enlargement of the inferior rectus. Here you can see that how much the superior rectus belly is enlarged. The doubt they had was why the superior rectus is involved first here if it is TRO. Because in TRO, usually the inferior rectus and the medial rectus are the first ones to get involved. Usually patient comes with a hypertropic eye. So their doubt was very good. And here they thought, okay, this is involved, why it's like that? Here, but belly is involved. And the TSH receptor antibody is negative. That was the doubt for them. So they informed the patient also about everything, and they sent the patient. And they started him on steroids, Visalon 30 milligrams. Now, we told the patient that it is definitely thyroid-related orbitopathy, nothing to worry. You are already on steroids. That itself will be a proof that, if it is going to stay the same, it is proved that it is not pseudotumor. Then the patient was convinced. He came after 2 weeks, and the eye condition was the same. There was not much improvement. So the diagnosis here is thyroid-related orbitopathy, where it is a euthyroid condition. It is an autoimmune disease, and it is possible. Not always it is related with hyperthyroid state. So how do we treat this patient? First of all, we have to look for coexisting myasthenia. 5% cases are associated like that. If it is present, we have to treat both the conditions. This shows only a mild response to steroids. If it is a severe inflammation, we get a good amount of response to steroids. And this worsens, smoking worsens this condition. So if the patient is a smoker, we have to tell him to stop it. And salt restricted diet, and when they sleep, the head and being raised will help the congestion which is setting up during the night. Or prisms and occlusions can be used, and eye lubricants. Now this patient, a lady who is 43 years old, she presented with pain and redness and swelling in the left eye and double vision of 2 days duration. So the onset here is sudden. So that tells us that it must be an inflammation. She had associated headache and pain was very severe at night. So the thought here was whether it is a myositis or a scleritis. The patient had horizontal double vision on left gaze, no history of discharge, trauma, fever or ENT or joint related problems. There was a similar episode like this 7 months back where she had drooping of the left upper lid, and that was treated as a third nerve palsy, probably due to pseudotumor with steroids, and it resolved for her. Now you can see here vision is 6/6, pupils and fundus were normal. You can see the congestion on the medial aspect, it is almost up to the limbus here. See the congestion, it looks like a pterygia, but it was not a pterygia. And the movements were very painful for her, mild adduction restriction and mild abduction restriction. Very painful to move the eye into lateral gaze. As I told you, you can see the underaction here and the overaction still presents like a paretic muscle only. And the blood investigations were normal, except that her ESR was 32 millimeters per hour. For her age, we would expect the ESR to be 25. And she was not willing for any investigation. This is the scan which was done 7 months back when she had the same episode in left eye when she presented with ptosis. Now she is not willing for any investigations because she is very scared and she is a widow. She does not have money also. So we got her agreed for a USG at our hospital. So this was the USG picture. Okay, we are thinking about pseudotumor here, but what we see in USG is a small cystic lesion with a small hyperdense lesion also, which is causing hyperechoic reflex. But if we see the previous episode scan, we can see the superior rectus muscle enlargement. We can see the tendinous involvement here. We can see in the coronal section that the superior rectus is much enlarged. So when we look at the scan picture, we think about pseudotumor because the tendinous insertion is also involved. But when we look at this USG, which is done this time, we see a cystic lesion. So are we dealing with the case of cysticercosis? Is the question here. But she is not willing for any confirmatory investigations beyond this. She is on a denial process. Now what do we do? Can we have a lesion like this in pseudotumor itself? It is possible. In pseudotumor also, we can have mixed signals like this. It could be an echinococcus cyst also. Now, she was also referred from another place. She was started on 40 milligrams of Visalon. This was after treatment. So, after 2 weeks of treatment, when she has taken 40 milligrams and 30 milligrams, this is the picture. You can see that the congestion is almost gone, very mild there. No pain absolutely, and the abduction is full and the adduction is full. So, that itself is a proof that it was an inflammation. Anyway, she is yet to come back to us again after 2 more weeks. Now, how do we differentiate thyroid eye disease and orbital inflammatory disease? Thyroid eye disease is usually bilateral and or asymmetrical, and orbital inflammation is usually unilateral. This has a gradual onset and this has an acute onset. This comes with severe pain, whereas TRO causes only a discomfort initially. And this has lid retraction as we see here, and this shows a ptosis. And usually with TRO, inferior rectus and medial rectus is first involved. With pseudotumor, any extraocular muscle can be involved. And TRO shows a moderate response to steroids, especially when the inflammation is moderate or severe. But with pseudotumor, as I showed you the case, it shows a dramatic response to steroids. In imaging, we can see that the muscle belly is involved in TRO, but the muscle up to the tendinous insertion is involved in orbital inflammatory disease. This small boy presented to us with pain and redness in right eye and double vision of 2 weeks duration, no history of trauma, fever or cold. You can see the abduction slightly restricted here and the adduction restriction here, and there was a mild congestion. On imaging, what we see here is a small ring enhancing lesion with the scolex inside. This was a case of orbital myocysticercosis, and he was treated with oral steroids and albendazole of 30 milligrams per kg, and he became completely normal. So, when we are facing a case of non-specific orbital inflammatory syndrome, when we have doubts, that is, it presents with mild or no pain at all, or it is with a chronic onset, or we get repeated recurrences, then we have to think that there is something which we haven't yet found out. We are not dealing with something non-specific, it's a specific etiology. What happens is, as more and more we apply our knowledge about the systemic diseases and autoimmune problems to orbit, the quantity or the group of idiopathic situations, it comes down. So we need an orbital biopsy to understand whether it is sarcoidosis or vaginous granulomatosis or lymphoma. I've just given few cases from a collection of cases across our branches. This is a case of lymphoma. You can see the Salmon's patch over there. This case is presented with ptosis for almost 6 years duration. You can see the Salmon's patch, which is pink and fleshy. This will be nodular and rubbery in consistency. This does not cause any compression or displacement. It molds along the globe. The biopsy would show the lymphomatous cells. Usually we get non-Hodgkin's lymphoma B cell type. You can see here in the imaging that both the intraconal and the extraconal compartments are involved. Pre-septal and post-septal areas are involved. Treatment would be with radiotherapy, localized. Systemic will be with chemotherapy. Sarcoidosis usually presents with the painless swelling, usually of the supralateral quadrants. She is a 66 years old lady who was presented with fullness and double vision. You can see in imaging that the supralateral quadrant shows tissues of mixed signals. You can see the fullness there also. And serum ACE was elevated. Biopsy shows a non-caseating granuloma. The treatment would be with oral steroids. In vaginous granulomatosis, this man is presented with proptosis of 7 mm and double vision. And you can see the transcompartmental soft tissue lesion over here. It's homogeneous. And CNCA was positive for him because he had a lung involvement also. And the biopsy has shown a necrotizing granuloma. Treatment would be with immunosuppression. Usually CNCA will be positive if there is sinonasal disease and lung involvement, and PNCA will be positive if there is renal involvement. When the patient presents with a myositis kind of a picture, and when we see enophthalmos instead of proptosis, we have to ask history about any cancer, and orbital biopsy would be the key for it. This is a case of orbital metastasis from breast carcinoma. This lady has got enophthalmos and myositis-like presentation. You can see the metastasis in the extraocular muscles and orbit. And an elderly patient complains about transient double vision in a setting of inflammatory orbital condition. We have to think about GCA. We need ESR and CRP. Steroids would be the line of management. And when we are trying to fix the double trouble, we have to follow an order. First, we have to recognize the ocular misalignment. Then we have to characterize the ocular misalignment. What is the type of deviation, esotropia or exotropia? And then quantify if possible with prisms. See whether it is comitant or incomitant. And then we have to think whether it maps to a cranial nerve or extraocular muscle or neuromuscular junction. Take a look at the pupils, visual acuity and fundus. Look for associated orbital signs. Look for associated neurological signs. Then we have to think now what is the anatomical site for this lesion. Then the probable nature of lesion. Then we have to do the test to confirm our clinical impression. Once we do this, we have the solution for the trouble and then we can easily treat it. Thank you very much for your patient hearing.